Welcome to Iswam Virtual 2021.
Yes. Good afternoon, everybody. Welcome back in Iswam Virtual 2021. Assalamualaikum warahmatullahi wabarakatuh. And thank you for rejoining this session afternoon. I'm Kisanti here again. We'll chair this fifth session of the round of Iswam Virtual 2021. In this afternoon, we will talk a lot about mesotherapy, application, and efficacy. With Honorable here with us, great speakers from France, Dr. Andrew Robert-Christie and Dr. Philippe Hamida-Pisal from UK. And I will remind again to all participants, you can type your question through the live chat during the session, and speakers will answer at the end of the presentation. Now let's get our first speaker. Good morning, Paris. Dr. Andrew Robert-Christie, are you there?
Good morning. How are you today?
Yes, I'm fine. Thank you. How are you?
Exceptionally well. Greetings from Paris.
Yes, I'm in Bogor. Bogor is the town at the south of Jakarta.
Significantly
town.
What I'm currently experiencing. It's -1 this morning. So I hope you...
it's so breeze. I hope you well, I hope a good condition and healthy. And I'm glad to have you here today.
Thank you kindly.
Yes, okay. Without further ado, I will read the CV from Dr. Andrew. Dr. Andrew is as clinical director and global medical trainer, equipment aesthetics, Dermapen World, Sydney, Australia, as medical director, lip service consulting, Paris, France. Dr. Andrew graduated from Macquarie University, Sydney, and the University of Southampton, UK. As professional experience, Dr. Andrew has appeared regularly on television and radio and in hundreds of interviews across the world as a master needler and authority on medical aesthetics. As the global medical trainer of Dermapen World, Dr. Andrew is the author of Advanced Innovation with Microneedling. And Dr. Andrew also authored 3 other books on skin needling and written over 600 papers for industry publication and journals. What amazing CV. And now we will ask Dr. Andrew, can start your presentation.
Of course. Greetings from Paris. It gives me great pleasure to be presenting today innovative revision of all scar types with automated microneedling combined in with mesotherapy infusion. For my disclosures, I'm the director of lip service consulting based in France, but also the global medical trainer and also the clinical director for equipment aesthetics based in Australia. When we have a look at the scar market, the value to us as aesthetic practitioners is rather astonishing. So marketing companies estimate that the scar market globally is going to be worth some nearly $35 billion by 2025. So we're currently seeing an exceptional growth rate each year of around about 9.7% per annum. We understand that globally, the treatment and revision of scar tissue is the third most common facial concern. Now, this follows the anti-aging phenomenon and then hyperpigmentation. But to create a little bit more precision, we understand that for the Indonesian market, particularly hyperpigmentation is the #1 aesthetic concern, followed closely by scar tissue and then followed by acne. We understand, particularly with the acne phenomenon, that atrophic post-acne scars are the most common type of scar that we treat in the aesthetic practice, with some 30% of patients who have experienced acne at any point and at any time in their life experiencing traditional post-acne scars, such as rolling, box scar, and ice picks. When assessing scar revision, we really need to take into account the risks, particularly for an Indian, Asian, or Middle Eastern morphotype. Our traditional modalities have included subcision, dermal stamping, and dermal rolling, but arguably we have very practitioner-dependent modalities with this. Likewise, also, we have devices which only have a preset depth, so it can't be customized for the patient. And particularly when we assess the dermal rolling market, although the needles do penetrate the skin at a 90-degree angle, some 75% of the revolution as the barrel turns are the needles cutting and arcing through the skin. This is problematic because we understand that for darker skins, any ablative procedure or any process that is going to rip or tear the skin may activate profibrotic growth factors or precursors to further scar tissue. Other considerations that are very common for the scar revision market include thermolytic procedures. So as such, we take into account laser, we take into account IPL, non-ablative and ablative fractional laser, so on and so forth, radio frequency. But we do also understand that for skins of an Indian, Asian, and Middle Eastern background, that the resulting thermolysis is a high risk for post-inflammatory hyperpigmentation. So the balance is trying to find the most ideal modality, however, a modality that is suitable and that is predictable for 100% of Fitzpatrick skin types and 100% of ethnicities coming into the practice, whilst ensuring that we minimize any risk, but also minimize any unwanted complications for this. Just exploring some generalized definitions with scarring itself. We understand that there is a trauma to the skin, but that trauma must extend from the dermis and beyond. The reason why is because scarring is abnormal collagen production. The cell which produces the collagen, of course, is the fibroblast. And as we don't find any fibroblasts in the epidermis, this is why our trauma needs to be dermis and beyond. Now, in response to the level of trauma as to how moderate or how severe that is, the body's response can quite often create a defective wound healing process. And we refer to this as cicatricial healing. So cicatricial refers to the Latin word for being upside down. We see a process as part of an accelerated proliferative response where we see the deposition of mature type 1 collagen, which is released too fast, too quick to try and re-epithelialize the area where the trauma has occurred. Now, scar tissue affects all Fitzpatrick skin types, affects all ethnicities, sexes, and ages. We also understand that following even a minor trauma, that if it is not appropriately cared for post-operatively, aspects such as wound tension and infection are also going to increase the risk of scar tissue following that initial micro trauma. We're going to categorize scars into 3 areas. It is either indented, which is referred to as an atrophic scar, Most typically, these will occur following acne. We take into account rolling scars, which are wave-like undulations, particularly following acne stage 2, papulopustular, or stage 3, nodular cystic. We take into account following acne boxcar scars, typically following nodular cystic or stage 3 acne, and then, of course, ice pick scars. Ice pick scars can follow nodular cystic acne, but can also be a feature of seborrhea, or an exceptionally oily skin, where we see dilation of the follicle. The final type of atrophic scar to take into account is referred to as an anetoderma. And this is a rounded pockmark, which generally occurs following chicken pox, or we can also see that via smallpox inoculations on the side of the arm. Moving from an indented scar by category, we then have a raised scar, and this is referred to as hypertrophic. A hypertrophic scar is where, by definition, it is controlled but raised. Where that raised scar is unstable and out of control, and we see farther unstable abnormal growth, we're going to refer to this as being a keloid. The final categorizing aspect to take into account is referred to as a contracture scar. Now, we have a combination potentially of atrophy, a combination also potentially of hypertrophy, but we also have contracture, and what we also have is binding of the skin. And we commonly refer to these as being either a post-traumatic scar, but this can also follow intense heat, so referred to as a burn contracture scar. So why treat scar revision with automated microneedling? Firstly, the value of any procedure that we offer to our patients must match the desires, the wants, the needs of the modern patient. We understand that the modern patient essentially wants the world and wants it now. The modern patient is looking for procedures that are affordable, procedures that are effective, procedures which don't have extensive downtime or commitment, but also procedures that are comfortable. This is the revolution of automated microneedling for scar revision of all types of scars. So it is non-surgical, so we don't require an operating theatre for its operation. There is absolutely no heat in an automated microneedling device. So therefore, it is suitable for patients who naturally have a risk for post-inflammatory hyperpigmentation, for patients who may not be suitable for thermolytic procedures, but now enables the versatility for all Fitzpatrick skin types and ethnicities coming into practice. With automated microneedling, the needles penetrate cleanly at a 90-degree angle, but exit cleanly at a 90-degree angle. So there is no turning of a barrel by comparison to a dermal roller. There is no multiple angling by comparison to something such as subcision. So with this, we have a non-ablative procedure. As such, the epidermis is kept intact. So following an automated microneedling procedure, the average patient is going to experience around about 36 to 48 hours of a mild to a moderate sunburn in both appearance and sensation. So under normal circumstances, you should never see bruising. You should never see any grazing. There should never be any track marks. And for a standard procedure, there should never be any flaking of the skin. In fact, with the automation or the oscillation of an automated microneedling device, what this can do is dissipate the nerve receptors and influence the patient's experience. So in fact, it is possible to perform this procedure without the use of a topical local anesthetic or injected local anesthetic. Likewise, also for treatment of a full face, let's take into consideration post-acne scars, it is an exceptionally fast procedure, which may be performed in as little as just 3, 4, or 5 minutes. As a fractional procedure, this therefore encourages a fast and comfortable post-operative experience. By contrast to microneedling stamps, to dermal rollers, at any point, at any time, the needle depth may be changed and customized based on the individual scars and based on the individual areas that you are treating. So in the market, we commonly see devices which will range anywhere from around about 0.2 of a millimeter right up to around about 3 millimeters of depth. So with this, we are able to obtain pinpoint precision for every patient, for every procedure, but for every type of scar, every time. Likewise, with the automation of the device, the practitioner is able to speed up the oscillation or slow down the oscillation. So in turn, this opens up opportunity for different styles of techniques, and I will cover these in a few slides' time. We take into consideration gliding techniques, which will be suitable for minor atrophic post-acne scars, but we can also take into account an imprinting technique, which can be used for a concentrated, precise work, particularly with drug therapy and mesotherapy combination for particular focus and revision of hypertrophic and keloid scars. So not only do we see the autologous regenerative medicine aspect and benefits of automated microneedling by the release of a controlled inflammatory and proliferative response, the release of regulatory growth factors, the release of scarless wound healing and collagen, and controlled angiogenesis, but we can simultaneously use this device for the infusion of mesoactives and drug infusion into the skin. But most importantly, it's predictable, it's reliable, and it delivers safety and efficacy for 100% of Fitzpatrick skin types and ethnicities coming into the practice. Now that we've established the benefits of automated microneedling, why combination therapies with mesotherapy or drug infusion for scar revision? Traditionally, mesotherapy are small injections of biomimetic agents or skin-recognized actives, such as vitamins and antioxidants, which are going to replicate the skin's own natural environment. And as such, the interaction and the introduction of these nutrition agents now encourage the skin to function with greater efficacy, but also increases the integrity and also functionality of the skin itself. Similarly to automated microneedling, it's a regenerative medicine. Now, regenerative medicine is the largest growth area that we see in aesthetics. And what we have is a phenomenon where essentially modalities and treatments are designed to work with the body's own process of healing, repair, rejuvenation, and regeneration. So whilst the traditional aesthetic uses and applications of mesotherapy have really been for anti-aging and to boost skin quality and integrity, I really want to open up the mesotherapy term with new approaches, but also with new updates to take into account that PRP really is a form of mesotherapy. Likewise, also appropriate drug infusion of steroid solutions, but also anti-mitotic solutions to further complement scar revision are a form of mesotherapy. So what we understand is that the combination of automated microneedling as a delivery mechanism serves as the ultimate synergy of solutions with mesotherapy for the revision of all types of scars. As an update, whilst traditional mesotherapy is injected into the skin, traditionally Nappage technique, rather than relying on the injections, we can use the automated microneedling device, which in some cases, devices on the market will deliver anywhere up to some 2,000 puncture channels per second into the skin. Although they are solid needles, the mechanics and the oscillation and the physics will physically push those mesotherapy and drug actives into the skin. So we see the benefit of this combination therapy here. the autologous regenerative effect that activates regulatory growth factors, regulated collagen production and angiogenesis from the automated microneedling device, but then also the infusion of biomimetic agents with that automated microneedling device. So a combination of mesotherapy for this. So as such, we now have a comfortable, fast procedure without the traditional bruising and without the traditional downtime. What about drug infusion as an update and a new approach as part of combination therapies, but as a wider terminology for mesotherapy combined with microneedling? This becomes an ultimate synergy of solutions, particularly for unstable hypertrophic scars and also for keloid and burn contracture scars. We understand that there are two benchmarks for this combination. First is going to be a steroid. The steroid of preference is triamcinolone acetonide. With this, there are some others that you may substitute if you don't have access to the triamcinolone acetonide, and that can either be a betamethasone or alternatively a methylprednisolone for this. However, the key experience is with the triamcinolone acetonide. As an intralesional injection prior to the automated microneedling procedure, what this is able to do is to provide further control to prevent signaling for further growth, and as such to deliver safe, predictable, and reliable combination therapies, particularly for keloid and burn contracture scars. The second key benchmark that has demonstrated key success is an anti-mitotic drug infusion. And in this case, we can actually use a topical 5-FU or topical 5-fluorouracil. Again, if you don't have access to this, there can be substituted with something such as imiquimod in this case. However, the key studies have all been performed with the fluorouracil. So as a chemotoxic, the combination of this, when applied following the automated microneedling procedure, as the puncture channels begin to close, now again further slows down intercellular signaling, but also begins to break down any large irregular deposits of abnormal or cicatricial collagen production. So mesotherapy as a wider term now takes us into the next level of scar revision, providing us for a synergy of solutions for the treatment of atrophic scars, for hypertrophic scars, but also for contracture scars, with suitability for all Fitzpatrick skin types and suitability for all ethnicities. As part of a comparison of traditional mesotherapy, but to ascertain and to guarantee the success of automated microneedling for infusion of mesotherapy and drug infusion agents, let's look at this comparison of these biopsies from RXI Pharmaceuticals. The first biopsy shows that if you apply a topical solution, a mesotherapy or PRP, onto the skin surface, it's not going to break through the skin's barrier function. This is problematic. If your active is not getting down to the dermis, which is where we have the abnormal collagen deposition, then we're not going to create any successful scar revision. The second biopsy shows what an intradermal injection looks like. So with these single injections, we can see that yes, indeed, this injection has bypassed the skin's acid mantle, and indeed the solution has now been distributed into the skin. You'll notice that with the small boluses that the distribution is quite localized for its placement within the skin, whether this is mesotherapy or whether this is drug infusion. The final biopsy is an automated microneedling device. It's operating at 108 revolutions per second, and there are 12 needles in the cartridge. So subsequently, it's delivering 1,296 puncture channels per second. Although these are solid needles, we see that the automation will physically push and force the active solution into the skin. And using a multiple striping technique, we see that the automated microneedling device can indeed administer an active meso solution into the skin, but then physically distribute that meso solution into the skin with far greater capability and potential, even by comparison to traditional nappage technique. So on one hand, this opens up a huge area of opportunity. And as supported by studies produced by Sultani Arab Shahi in 2014, we see that these microneedles really are a powerful mechanism for transdermal delivery of mesotherapy and drug infusion actives. So we open up our infusion, we open up our delivery system of mesotherapy, of drug infusion for steroids and for anti-mitotics, but new ways to furthermore deliver without injection agents such as PRP, but even for agents such as nanofat. The traditional way to determine the severity of scar tissue was identified by the Goodman-Barron system in 2006. Looking and assessing a new approach and updates to the Goodman-Barron system, I want to use this scale to now determine how exactly you can implement new techniques and approaches with an automated microneedling device. For example, with the Goodman-Barron 1, 2, or 3, we notice that there is a very, very mild to moderate contrast in topography, whether the scar tissue is atrophic or whether the scar tissue is slightly hypertrophic. As such, with this, we can promote a gliding technique via an automated microneedling device. This is a fast striping technique that produces the mechanical breakdown of existing atrophic or hypertrophic scar tissue while simultaneously infusing the mesotherapy active into the skin. However, for a Goodman-Barron 4, where we have a great contrast of topography, whether that is atrophic, but namely in these cases, we're looking at major hypertrophic or keloid scars, where there is a great contrast, we can actually implement what is called an imprinting technique. Imprinting is very different to traditional stamping technique. And what it delivers is a concentrated and precise delivery of the needles for a faster mechanical breakdown of the existing scar tissue, whilst simultaneously delivering a mesotherapy or drug infusion as part of this. So for glide technique, you will want to use this for a Goodman-Barron 1, 2, or 3. So if the scar tissue is macular, for a Goodman-Barron 2, if it is slightly atrophic, or for a Goodman-Barron 3, if it's moderate atrophic or hypertrophic in this case. Implementing a gliding technique, you will require a gliding medium for all automated microneedling devices. Do not use this device on the skin dry. Saline is not a good conductive agent. Likewise, PRP itself is not a good gliding agent. So you will require something that will lubricate the skin, but serve as a dual mesotherapy. So consider something such as a non-cross-linked hyaluronic acid gel. These can be reinforced with agents such as retinaldehyde, copper peptides, which now provide the dual benefit of both automated microneedling, but also infusion of mesoactives. For successful glide technique, you will want the automated microneedling device at fastest speed. This means that it will not catch on the skin. Likewise, you will want a stripe technique, which will follow vertical stripes, followed by horizontal, diagonal 1, diagonal 2. So if you think of the flag of the United Kingdom, you will want to adjust your needle depth to achieve a visual endpoint, not a mathematical endpoint. With microneedling, there is always this risk for practitioners to want to treat at the deepest depth. This is not always going to be so precise. In fact, in 2008, Matthias Aust and Des Fernandez, the pioneer of dermal rolling devices, found that you can deliver the same level of collagen activation, stimulation, regeneration, and synthesis from 3 millimeters of depth as what you can with just 1 millimeter of depth. So for a visual endpoint, if the scar tissue you see is red, blue, or purple, your visual endpoint as a minimum is going to be pinpoint blood. However, if the scar tissue is very white, if it's old or very dark, then you will want to create a moderate release of blood. So we see for this patient here, we are applying a mesotherapy solution. It's a 35 milligrams of non-crosslink hyaluronic acid gel. Now, this is our vertical stripe technique. So just following in the one direction, horizontal stripe. This will be followed by diagonal 1, and then the second diagonal. You see that at top speed and at the right depth, we are achieving the right visual endpoint of pinpoint blood, ensuring that we are reaching the right layer of skin and interacting with the right response in order to mechanically break down that existing scar tissue. So the success of mesotherapy, but the success of glide technique can be achieved and deliver patient results in as little as one procedure for this first patient case study here. The mesotherapy is just a straight 10 milligram hyaluronic acid gel, as is with the second patient with a post-traumatic scar. So we see that the gliding technique is suitable for a Goodman-Barron 1, 2, and 3. Ensure that your device is at the fastest speed, and likewise ensuring that you are using a striping technique. The traditional technique for hypertrophic scars is usually to incorporate some type of stamping or subcision. Imprinting with an automated microneedling device is an update on traditional subcision and stamping. So we can select anywhere with devices on the market up to some 3 millimeters, but rather than freehand stamping that device onto the scar, by simply holding it into position for around about 3 to 4 seconds, the needles will then penetrate through the scar tissue, allowing for a mechanical revision, but also the simultaneous infusion of mesotherapy and drug infusion actives. We will want to incorporate an imprint technique, particularly for a Goodman-Barron 4. So we are looking at bound, pulled hypertrophic scars. And as part of drug combination therapies, we are looking at keloid scars as well. In order to achieve the best effect for an imprint technique, you will want to reduce the oscillation or the speed of your device to the lowest setting. So at the lowest setting, then select the appropriate needle depth. So if the scar tissue is red, blue, or purple, whatever needle depth will deliver pinpoint blood. Or if the scar tissue is old, if it's very white or very dark, then increase that needle depth so you're achieving a moderate release of blood. First, we're going to hold the device at a 90-degree angle, and then we're going to re-angle the device, whether that is twice or whether that's going to be 3 times, to further increase the mechanical breakdown of the scar. So you see that we may need to support the skin in this case. You will still require a lubricating mesotherapy medium. So we're in at a 90-degree angle, and then we re-angle and re-support that skin and hold the device for around about 3 to 4 seconds. So begin at a 90-degree, and then we will go in anywhere from a 45-degree to a 65-degree angle until we achieve the desired visual endpoint. So what we have is a far more precise way, particularly if the scar tissue is bound, but as part of combination therapies for the treatment reduction of keloid scars. So for the first patient case study here, we see the benefits of an imprint technique, but the simultaneous infusion of a hyaluronic acid mesotherapy for treatment of a hypertrophic and atrophic nodular scar. This is following one procedure. Likewise, also, we see the success by supporting the skin that you can use imprint technique also for an atrophic scar. So it's not always required for a hypertrophic scar. And our third patient case study here, there is a mesotherapy infusion of a non-cross-linked hyaluronic acid plus a retinaldehyde. So no drug combination therapies for any of these patients. And then using an imprint technique at multiple angles has delivered success even after one procedure. So what mesotherapy agents can we use and for what type of scars? We understand that for atrophic, for post-acne scars, but for stabilized hypertrophic scars, we have the benefit of mesotherapy agents, including hyaluronic acid, retinaldehyde, copper peptides, but also PRP or even nanofat. Likewise, also for atrophic post-acne scars, particularly for boxcar and ice pick scars, you may want to incorporate something such as a TCA cross applied immediately following the automated microneedling procedure. So quite simply, the automated microneedling device creates the puncture channels, which will therefore deliver greater infusion of the chemical peel active. Note that this combination therapy is only suitable for Fitzpatrick skin types 1, 2, and 3 and very early 4s. If there is a risk of post-inflammatory hyperpigmentation, this is not an appropriate combination therapy. However, for a stabilized hypertrophic scar, another option for a drug combination therapy is to apply a topical fluorouracil or 5-FU cream following the procedure as the puncture channels begin to close. And this will accelerate the flattening of that lesion. However, for unstable hypertrophic scars, for keloids, and for burn contractures, we can begin the procedure firstly with an intralesional injection of triamcinolone acetonide or Simla, something such as a betamethasone or alternatively a methylprednisolone. Then perform the automated microneedling, which will distribute the steroid solution whilst mechanically breaking down the existing scar tissue, but also infusing the mesotherapy agent, such as hyaluronic acid. And then following the procedure, as the puncture channels are closing, we can then apply the anti-mitotic to further flatten the scar. So for our standard treatment for standard atrophic or post-acne scars, cleanse and disinfect the skin, removing any topical local anesthetic if it's been used. Bear in mind that with the oscillation of automated microneedling devices, it can dissipate the nerve receptors, so it's possible to perform treatment without use of a topical local anesthetic. We're then going to apply the mesotherapy medium, either via a syringe or just using the fingertips, onto the skin topically, and then infuse that into the skin with the automated microneedling device using a combination of gliding or imprint techniques. Needle until the desired endpoint is achieved, whether that is pinpoint blood or more blood, and then we're going to remove any procedural residue and apply our post-operative care and repeat treatment every 6 to every 8 weeks. So we're distributing, for this patient's case, the mesotherapy solution for revision and treatment of post-acne, ice pick, and boxcar scars. As we release the solution, we then apply the automated microneedling device. This is gliding technique, and it is using a stripe technique. So vertical, horizontal, diagonal 1, and then followed by a diagonal 2. And you'll start to see the pinpoint blood is now coming through. So we've achieved the appropriate desired endpoint. Now, moving from a glide technique, we are now implementing an imprint technique. So reduce the speed all the way down to its lowest setting, and then hold in place at potential multiple angles for around about 3 to 4 seconds each time to allow for a more concentrated and precise breakdown of any hardened scar tissue. So the type of results we can see for these are fast, effective and comfortable for the patient, but suitable for all Fitzpatrick skin types and ethnicities. So we see success for the first patient for post-acne rolling scars with a mesotherapy infusion that is a non-cross-linked hyaluronic acid and a retinaldehyde. For the second patient here for treatment of post-chickenpox and netodermic scars, we have a mesotherapy infusion that contains tyrosinase inhibiting kojic acid dipalmitate, but also 10 milligrams of a non-cross-linked hyaluronic acid. For both these patients, it's a gliding technique. What about for post-acne ice pick and boxcar scars where the patient is suitable based on their Fitzpatrick skin type and based on a low risk of post-inflammatory hyperpigmentation for an update of chemical peel combination therapy or cross technique? So really, this is still a form of mesotherapy introducing an active into the skin. So again, we're going to clean the skin, disinfect, remove any topical local anesthetic. We will then microneedle the skin utilizing our mesotherapy or PRP and a combination of gliding and imprinting techniques until the desired visual endpoint of pinpoint blood or more blood has been achieved. Remove the residue and remove any blood. The reason why blood has a pH of around about 7.48 and your mesotherapy solution may have a pH between about 5 to 7. So we don't want that to neutralize the chemical peel. Utilizing with a toothpick or a modified dental or tooth cleaning stick, you can then apply the cross or chemical peel, and cross is the chemical reconstruction of scars and striae. A TCA or a trichloroacetic acid combination therapy can simply be dipped into the individual lesions. So the visual endpoint of this is frosting. So this is a modified tooth cleaning stick that has a tiny sponge on the end. It's been dipped into a 35% TCA solution, also containing 7% salicylic acid and 1% beta lipohydroxy acid. You can see as soon as it touches inside the atrophic scar, the instant frosting. So this means that it neutralizes straight away. So the object of this combination therapy follows the automated microneedling and mesotherapy infusion, but you must apply the solution physically into the area of atrophy. Not on, not around the skin, but into the area of atrophy to minimize your risk of post-inflammatory hyperpigmentation. So for these 3 patient case studies, the first patient, we see the application of 35% TCA with a toothpick applied following 3 automated microneedling treatments and a mesotherapy combination with hyaluronic acid gel. For the second patient, we have 6 procedures here. The infusion of mesotherapy with hyaluronic acid and retinaldehyde with the automated microneedling, but then applied is a 35% TCA, also containing salicylic and a beta lipohydroxy acid. We see again for the final patient that just following 3 procedures that this cross technique and this update and new approach to mesotherapy can accelerate your treatment results. This is only suitable for atrophic post-acne scars. Our final is our drug combination therapy. And this is suitable for an unstable hypertrophic scar, for a keloid, or for a burn contracture scar. So again, we begin with cleansing of the skin, disinfecting, removing any anesthetic. We begin with an intralesional injection of triamcinolone acetonide, 10 to 40 milligrams or similar, around about 0.03 of a milliliter to 0.05 of a milliliter per injection site. The success of your placement of your injection will be indicated as you massage the area. You'll notice that it blanches slightly. Wait a few minutes and then apply your lubricating mesotherapy agent onto the scar, and then use your automated microneedling device, a combination of gliding or imprint technique. This not only mechanically breaks down the scar tissue, but then will physically distribute the steroid solution into the scar, allowing for greater safety, predictability, and control. Once you've achieved your desired visual endpoint of either pinpoint or more moderate blood, remove all treatment residue and then apply just half a rice grain or a very, very tiny pinpoint amount of topical fluorouracil cream, so 5-FU or similar, and simply massage in and leave for at least 8 hours. We want to repeat this treatment no sooner than every 6 weeks. So for this C-section scar, we begin with the intralesional injection before the microneedling of the triamcinolone acetonide. So in this case, it's just 10 milligrams. So around about 0.03, 0.05 of a milliliter per injection point with this. Following the injections, we're now going to distribute the solution with the automated microneedling device. So we're going to apply a gliding medium, this case, a base hyaluronic acid gel, and this is just going to allow for free movement and lubrication of the automated microneedling device. Massage that through, and then we're going to use a combination of gliding techniques and a combination of imprint techniques. So in this case, this is beginning with imprinting technique. This is also distributing and administering the steroid solution that was injected as a pre-op intralesional injection. And what this will also do is mechanically break through the scar tissue as well. However, following our imprint technique, we can then use a glide technique to accelerate the mechanical breakdown, but also the distribution of the steroid solution into the skin. Once we have microneedled to the desired endpoint, we simply conclude with an application of the anti-mitotic. In this case, it's a very small amount of 5-FU that's massaged in over the top, and its infusion will be facilitated as the puncture channels begin to close following the microneedling procedure. So the ingenuity of this synergy of solutions provides success for treatment of keloid scars. For this first patient, this is the 3-in-1 of intralesional steroid injection, automated microneedling with a base hyaluronic acid mesotherapy, but also infusion of the anti-mitotic. And this is before and after 4 procedures. It's also 4 procedures for the second patient here. This first patient for a burn contracture scar has undergone multiple procedures of just standard microneedling, but the last 2 sessions, which were the synergy of the steroid, the synergy of automated microneedling, plus the anti-mitotic, have been described by the plastic surgeon as life-changing for the patient. And finally, for this burn contracture scar, we see success even without drug combination therapy. So this is just a mesotherapy infusion of a hyaluronic acid that is non-cross-linked. So as such, we see success. So the ingenuity of automated microneedling plus new approaches to mesotherapy, opening up the pathways for PRP and for drug infusion, now provide a safe, predictable, but affordable scar revision that is suitable for all scar types and suitable and safe for all ethnicities and Fitzpatrick skin types coming into the practice. I'm Dr. Andrew Christie Schwartz. Thank you so much.
Thank you so much, Dr. Andrew, for your interesting presentation. Innovative revision of all scar types with automated microneedling combined with mesotherapy and drug infusion. You describe it so clearly that we can technically do in our practice. We have a lot of questions.
Of course.
Interval. For the interval for microneedling, when we combine with the laser and peeling, how long it could expect the patient to see result after treatment with Dermapen?
Okay, so if you're performing the laser or the peels as an individual procedure, so you will want to probably treat them roughly every 4 to every 8 weeks. And then you would continue with your automated microneedling at again around about 6 to 8 week time periods. If you wish to combine the modalities together, you will want to perform at roughly 6-week intervals. So your first procedure may be microneedling, or it may be laser. Then 6 weeks later, continue with microneedling or laser. So you want to alternate at roughly 6-week intervals. For the average patient, even for a standard automated microneedling program, you'll want to treat roughly every 6 to every 8 weeks. This means that we're working in with the natural proliferative response as part of wound healing, but avoiding creating multiple wound healing responses. And this is going to risk the release of profibrotic growth factors, which in turn can contribute to abnormal collagen deposition, but also post-inflammatory hyperpigmentation. Particularly if you're going to use the steroid injections, again, to prevent any unexpected complications or atrophy no sooner than every 6 weeks. But for chemical peels, you've seen that the innovation of something such as a medium depth TCA cross can be applied immediately following the automated microneedling procedure. So we see the success with this, which can now deliver an innovation. But what this can also do is deliver for the patient a unique way to accelerate their results. I'm trying to get that slide to come back up again. Unfortunately not.
Oh, thank you for the answer. And there any contraindication for treatment with Dermapen?
So for treatment with Dermapen and with the automated microneedling, we don't see any risks or complications. There is a suitability for 100% of Fitzpatrick skin types and ethnicities coming into the practice. However, be careful of intervals. You want to make sure that you are not treating for scar tissue more frequently than every 6 weeks. So roughly every 6 to 8 weeks. Likewise, also with this chemical peel combination therapy, you've got to make sure that the patient is not a risk for post-inflammatory hyperpigmentation. And as we see with the technique for the patient for chemical peels, it's understanding that it is just a pinpoint application into the area of atrophy, not around, not on the surrounding skin or tissue, but physically into the atrophy. So again, we can minimize any complications of post-inflammatory hyperpigmentation.
Oh, okay. And in the combination with TCA cross, how about we do the TCA cross before the microneedling? Is that necessary?
Afterwards. So if you do it first, what we're going to create is a level of exfoliation. And there's always been a thought process that if you exfoliate the skin first, then somehow that's going to assist in the penetration of the needles with your automated microneedling device. The reason why this one's a little absurd is because we're not talking about 2 millimeters or 3 millimeters of dead skin cell buildup on the skin surface here. So with that, there's no major benefit to exfoliating the skin prior to the automated microneedling device. So with this, let's maximize the channels of the automated microneedling device. So you can physically deliver the TCA down the channel, which means you have perfect placement. So this also delivers precision because it keeps the epidermis intact. So you're not having to burn the entire epidermis to get down to the right level. You're utilizing the fractional channels that are delivered by the automated microneedling device as part of your delivery mechanism and system. So I recommend where appropriate, based on the patient's Fitzpatrick, but also low risk of post-inflammatory hyperpigmentation, application of the TCA cross or the medium depth chemical peel with a toothpick applied after the automated microneedling. Just make sure you remove any blood or any treatment residue so that this doesn't neutralize the peel or its acidity.
Oh, thank you for the answer. And in the question from the box, I have difficulties on hyperpigmentation for a post-op surgery scar. How to manage it with microneedling to maximum result?
Perfect. So for treatment of hyperpigmentation, we're going to be targeting a different area and aspect within the skin. So today's topic about scar tissue, in achieving the visual endpoint of blood, our focus is for the needles to target down directly to the affected fibroblasts or collagen producing cells and to mechanically break up that existing scar tissue. Now, it is not uncommon, particularly due to background and ethnicity, that many patients experiencing trauma not only see a scar, but also see a post-inflammatory hyperpigmentation. In that case, we understand that the affected cell is a melanocyte. The melanocyte resides in basal epidermis, and under normal circumstances, the melanocyte hands over the melanosome or pigment capsule into the keratinocyte, and that occurs spinosum epidermis. So it is possible, following your deeper automated microneedling procedure with blood, which is what we've performed today, 4 weeks after the procedure, to perform a more superficial microneedling. So more superficial means that you're targeting directly the melanocyte. So you want no blood as your visual endpoint. Now we can customize this. So why not use a mesotherapy agent that combines specialized tyrosinase inhibitors? So you're using the microneedling to not only regulate the release of melanocyte growth factor and epidermal growth factor, but you're also using the device to deliver appropriate tyrosinase inhibitors. These could include agents such as a kojic acid dipalmitate, a magnesium ascorbyl phosphate, or a non-acidic vitamin C, or this could even be something such as tranexamic acid. And so we have a more superficial infusion, which can allow for a pinpoint precision for post-inflammatory hyperpigmentation. So we would be alternating our depths. The first treatment with blood, then 4 weeks later, a superficial treatment with no blood, using your infusion of mesotherapy tyrosinase inhibitors. 4 weeks later, blood, 4 weeks later, more superficial. So we do see the versatility with microneedling that takes us above and beyond just treatment of scar tissue. We can see success with hyperpigmentation, drug combination therapies for hypopigmentation, but even innovations for acne, alopecia, and rosacea.
Oh, great. It's more question from the box. It's any Dr. Andrew, may I ask if there's any alternate than 5-FU cream for topical post microneedling?
Is there
any alternate than 5-fluorouracil cream for topical?
Can't access the 5-fluorouracil. The other option is to use something such as a Miquamod. So if you just have a look at the base of this slide here, as a substitute for 5-FU, you can try a Miquamod, and also as a substitute for the triamcinolone acetonide, you can try something such as betamethasone or methylprednisolone for this.
Oh, yeah. Dr. Maria Angelina asked, microneedling for hypertrophic scar using what kind of speed for hypertrophic scar? And
so we go back to the Goodman-Barron scale in this case. So if the hypertrophic scar is a Goodman-Barron 3, so it's mild in this case. So we are looking at these types of scars. Sorry, I will get to the right slide. We're looking at these types of scars. So you can actually use a gliding technique for this. So for a gliding technique, you want fastest speed. That ensures that the needles will not catch or drag on the skin. So if you feel that the needles are dragging on the skin, there are 2 reasons why. Either your needles are too deep, or alternatively for that, your speed is not fast enough. Always make sure that you're using an appropriate lubricating mesotherapy gliding medium to ensure that the needles can freely move across the skin. If, however, it is a Goodman-Barron 4, rather than utilizing your glide technique, you will then want to utilize your imprint technique. And this is where you are going to reduce the needles down to the lowest speed. And rather than physically gliding and striping with the device, as you can see here, we're going to hold it in position for around about 3 to 4 seconds. take the needles out, re-angle and re-support the skin, and then back in. So this is really dependent on the type of scar and the level of severity for the hypertrophic scar in this case.
Okay, thank you. Dr. Andrew, from Dr. Melissa, what do you usually use for post-treatment home care for scar? Yeah.
Home care, yeah. I recommend a post-operative treatment that is a non-balm or non-occlusive or oil base. So with this, you want something that is a water-based product. I have a preference for using a range called DP Dermaceuticals that is specific for automated microneedling. What also I recommend, particularly for post-scar revision, is a silicone gel. So I personally use a product called Scar, which is 7 types of silicones, plus also zinc and tyrosinase inhibitors. And this can be applied multiple times throughout the day for the patient as part of their post-operative care. So ensuring that what you use post-operatively allows the skin to breathe. So not anything that is exceptionally oily or balm, something that is a water base. And then also the advantage of a silicone gel can also be used as part of post-op. Sunscreen is still a non-negotiable, whether it is summer, fall, whether it is spring, whether it is winter. Patients should always be wearing sunscreen to avoid any complications of post-inflammatory hyperpigmentation.
Yes, thank you. Another question from Dr. Maria Angelina. Is it okay to do microneedling on acne active skin because of the scar purpose?
I do treat on acne stage 1, 2, and 3. So comedonal, papulopustular, and nodular cystic. I don't treat on acne stage 4, which is acne fulminans or acne conglobata. Now, the thought process generally would be that if you microneedle an active acne skin, then wouldn't you be spreading P. acnes bacteria all around the face, which is therefore going to make the acne condition worse? Not so. We understand that the P. acnes bacteria is anaerobic. So if you are adding in with an automated microneedling device some 2,000 microchannels throughout the procedure, then these microchannels are going to deliver into the skin oxygen. And that in turn is going to kill the P. acnes bacteria. So you see with this patient here that we have a combination of post-acne scars, but we also have some active acne there. The other advantage of this is what creates and what contributes to the post-acne scars is once we begin to see the presence of P. acnes bacteria, particularly within the follicle, this in turn can create an imbalance of enzymes, which in turn can then begin to attack the follicular wall. So using oxygenation simply via the automated microneedling device to reduce the P. acnes bacteria, then also reduces the enzymes, which in turn will slow down the eventual formation of post-acne scar tissue for this. The patient can still be treated if they are on oral antibiotics for acne, even if they're using topical antibiotics for acne. Just a couple of precautions if the patient is on an oral isotretinoin. If they're on a dose which averages out to around about 30 milligrams a day or less, you can still safely treat with automated microneedling. But if they are on a high dose of isotretinoin, I wouldn't treat with automated microneedling or any of these combination therapies for at least 6 months after they have concluded their course of high-dose isotretinoin.
Oh, yeah. It's one more question. After that, you can conclude the session. How is the microneedling result on hormonal acne and mask-induced acne, Doc? So, hormonal acne and mask-induced acne.
Okay. So what we need to understand is what is the trigger and what is the source of that acne that is coming through. So for hormonal acne, one aspect that we can take into consideration is going to be control of the movement of the androgen hormones. So with this, what we want to do is keep balance of the testosterone into the dihydrotestosterone. So in some cases that may require a contraceptive pill kill that may require some type of anti-androgen medication to try and obtain some stability. We also see that some natural supplementation, including zinc, can also rebalance the 5-alpha reductase production with this as well. So you can incorporate and you can still treat if the patient is on an anti-androgen medication. When it comes to something such as masked knee, please replace your mask frequently throughout the day. So if you carry a disinfectant spray and spray the inside of your mask, but also your skin throughout the day, but as soon as you feel that you are accumulating droplets within your mask, replace your mask. And that is going to be one key but very simple tip that you can reduce the effects of masked knee as well. But Dermapen treatments can be treated as frequently as every 2 to every 4 weeks, more superficially, and you can use a specialized combination of agents to treat for acne stage 1, 2, and 3.
Okay. I think it's the end of your session today. Thank you for your explanation. I believe that all participants get the benefit for treating the acne scar and with the innovative revision with the automated microneedling combined with mesotherapy and drug infusion. Thank you for your time.
Thank you so much.
Yes, I hope you in good health. Bye-bye.
Thank you. Take care.
Thank you. Yes, take care. We will continue for the next interesting presentation about hair loss treatment, but after this commercial break. Welcome back to Iswam Virtual 2021 6th session. Today we can meet again. I'm Santi, Kesanti, here again to discuss with Dr. Hamida Phillips Hamida Pisal, sorry, for United Kingdom. An interesting topic today, combined treatment botulinum toxin and mesotherapy for hair loss. Here with us, Dr. Philip. How are you?
I'm good. Thank you very much.
Yes.
Selamat datang. Thank you.
Thank you. I'm very proud to be your moderator today.
Thank you so much.
You are in Paris right now?
Yeah, I'm in the south of France, Biarritz.
Oh, south of France. I hope things safely under control during this pandemic and wish you always in good health.
Yes, everything is fine. Thank you very much. I hope for you too.
Now let me read your profile. Dr. Philippe Hamida Pisal, key opinion leader for leading French companies and is the pioneer of the French touch. He is currently the president of Society of Mesotherapy of the United Kingdom, SOMUK, as co-director of the Society of Mesotherapy of South Africa, SOMZA, and he is an aesthetic practitioner specialized in dermatology. He is a founder and managing director of PHP Aesthetic and PHP Wellness, divisions of PHP Health First. Dr. Philip Hamida Pisal will be present the combined treatment botulinum toxin and mesotherapy for hair loss. Time is yours.
Thank you very much. Selamat datang Indonesia. Hello Indonesia. It's always a pleasure to be. I used to go to Indonesia quite a few times for presentation. Unfortunately, with the situation, so please all stay safe. Bonjour, bonjour la France, and good morning everyone in Europe because we have a different time zone. Thank you for inviting me to talk about this interesting topic of, hair loss or hair quality, alopecia, if you want to talk differently. Because when we do the consultation, we always have, when we push the consultation further, we always have a patient, in fact, they are concerned about their hair. So when we ask a lot of questions, because the most important is the first consultation, then they are concerned about, their hair, they break easily, they're very dry. So we have to offer a treatment. We used to have only mesotherapy where we do a 10 session. 10 session is intense for the patient. And so we've decided to work on a combined treatment, mixing botulinum toxin and mesotherapy, which enable us to have only 3 sessions, to repeat every 6 months. We're going to see it later, but also easier for our patient because for the compliance, for them to come in our clinic, in-house clinic, it's easier and they can see the result, within a few weeks. So let's recap a bit of, what do we call alopecia? So alopecia is a partial or total hair loss, okay? And we know that there is the hair, they've got a symbolic meaning for force and seduction. Hair equals strength and appeal. And it has in many cultures, there is a sexual and religious sign. So few information not to remember, but to know: density of the hair, the number of the hair, diameter of the hair. The growth per month everything is an average, 1 to 1.5 centimeters. Lifespan, 2 to 7 years. And obviously it depends where we live. It depends on what we're doing with our hair, okay? Number of cycle and resistance, it's 100 gram resistant when we pull the hair. So what the patient really are the main concern? What are the main concern when they come to see in our clinic? Is they want beautiful hair, glowy, bright, smooth, soft, less dry, less breakable, easy to blow dry for the modern and active woman, less thin, more firm, more resistance and better tolerance to chemical agent, because more women and men use chemical agent, and finally to treat the hair loss or to improve the alopecia. So just incidence, we know that alopecia increases with the age, okay? In a Caucasian population, 70 to 80% of the men and 42% of the women between the age of 50 and 70 show sign of already pattern baldness, the most frequent type of hair loss. In ethnic population, we've noticed in UK an increase due to the use of chemical agent and of course, cultural, okay? So we know that androgenic alopecia is the most common form of alopecia in male and female patients. So what do we know about the hair cycle? There is 3 phases. There is the anagen phase, there is the catagen phase, and then there is the telogen phase. We know that the anagen is an active growth phase, which lasts between 2 to 6 years. And, in that phase, we've got, this is very interesting, we've got 85 to 90% of the follicle are in that phase. Then we have an involution phase, which we call catagen, which lasts approximately 3 weeks. And finally, we've got a resting phase called called telogen, which lasts between 2 to 6 months, during which preparation are made for growing a new hair shaft. So what we tend to forget is the aging factor of the skin are exactly the same as the aging factor for the hair. So we've got internal factors, mainly genetic, but we've got external factors which are environmental, oxidative stress, sun exposure, and like was saying Dr. Andrew, SPF is paramount, and we need to use SPF specific for the hair as well. So sun exposure, UVA and UVB. Smoking, emotional stress. We know that emotional stress is one of the causes as well. Water and moisturizer, cosmetic, and also, chemical agent, relaxers, waivers, and so on. What are the consequences for our hair? Okay, so reduction in the length of the growth phase, reduction in the hair shaft diameter. So if they reduce in the diameter, they're going to break more easily, decrease in the elasticity, and growing. Let's see a diagnosis. We know that the formation phase of anagen, the first one where we've got 85 to 90% of the hair follicle, which are in that phase, requires growth factors and nutrients, iron, protein, zinc, vitamin, and oxygen. And we know that with the mesotherapy, we provide all those nutrients. What do we know as well? We know that estrogen and thyroid hormone promote the growth of the hair follicle. This is a fact, okay? And what do we know as well? Testosterone undergoes a change which is linked to the 5-alpha reductase, which change the testosterone into a more potent androgen, which is called DHT or dihydrotestosterone. And unfortunately, the DHT, dihydrotestosterone, reduce the size of the hair shaft of the diameter. And the DHT is then responsible for the hair to become more thin and to break easily. So 5-alpha reductase is the enzyme that converts testosterone into a much more potent androgen, DHT. We saw it previously. Okay, so if the 5-alpha reductase increase, obviously, there is more testosterone will be converted into DHT, and greater the hair loss will result. And we know there is two 5-alpha reductase. There is type 1 and type 2. Type 1 is mainly into the sebaceous gland that produce the skin natural lubricant sebum. So then, this is not the subject. It's why it's very interesting when we want to treat the acne in the subject previously, rosacea. So the first one is very interesting. But what is our concern is the 5-alpha reductase type 2, which is mostly sit in the genital area and the hair follicle. So in that case, the type 2 is considered more important in the process of the hair loss. So we're going to target the 5-alpha reductase type 2. There is few experience which studies suggested that subcutaneous blood flow in the scalp of a patient with mild pattern baldness was greatly reduced as compared to control patient. Goldman and al. Conducted an experiment in which they measured the partial pressure of oxygen of the scalp in male pattern baldness, and to find out whether bald scalp actually had some microvascular insufficiency, if it was less oxygenated than other area. They found that resting transcutaneous partial pressure was significantly lower in the frontal bald scalp, the frontal one, compared to the temporal hair-bearing scalp in patients with mild pattern baldness. It's why we always see the baldness into the frontal area and never in the temporal area. The partial pressure of oxygen in frontal bald scalp was also significantly lower compared to hair-bearing frontal scalp of control patient, and also of hair-bearing frontal and temporal scalp in control were not significantly different. To summarize, this relative microvascular insufficiency possibly result because frontal and vertex areas are supplied by supratracheal and supraorbital arteries, which are smaller branch of internal carotid artery, and it overlies the gallia aponeurotica, which is relatively less vascular as compared to the temporal and occipital area, which overlies muscles. So what does it mean? It means that in some area where the microcirculation is very thin, it's mainly always a time where we see the baldness. And when the area has, you know, a good oxygenation providers, there is lower risk of to have hair loss. So what is the technique of the mesotherapy combined with botulinum toxin? So is the 3 session, space of 2 weeks to 3 weeks maximum. The first session is a combined mesotherapy and botulinum toxin, obviously not mixed together. At the same session, we inject the botulinum toxin and then straight away do mesotherapy afterwards. Then the second session, 2 weeks of mesotherapy by itself. And the third session, mesotherapy again by itself. And we repeat the technique 6 months after the first session, so twice a year. So what are we going to use the botulinum toxin and where are we going to inject? The injections are intramuscular and the site selected are frontalis, occipitalis, temporalis, and periauricular muscles. Obviously, the botulinum toxin target the muscles. So what is the rationale behind, okay, the effect of botulinum toxin? We know that there is a cascade of impact on the sebaceous gland, the keratin, and finally on the hair quality, straightening, and brightness. Secondly, we know that the conversion of testosterone to DHT is increased in a low oxygen environment, while in a high oxygen environment, DHT is converted to estradiol. And you remember, estradiol, estrogen, promote the hair growth. So then by injecting botulinum toxin in the peripheral musculature, what do? We achieve a decompression of the perforated blood vessel through the relaxation of the muscles, and then we have an increase in the oxygen delivery to the frontal and coronal area of the scalp. More oxygen, it means, you know, less DHT, more estradiol, and we've got an inactivation of the 5-alpha reductase, double effect. So in the protocol, we dilute 50 units of botulinum toxin with bacteriostatic cell line to be injected. So where we're going to inject, we're going to inject into the frontalis, then temporalis and occipitalis, where we have the muscles, okay? So 50 units for the whole scalp. You can increase to 75, obviously, if the alopecia is quite important, but minimum 50 units. Then, second, straight away after, we inject the mesotherapy cocktail. So where do we inject the mesotherapy cocktail? Obviously, we're not going to inject mesotherapy cocktail when we don't have sign of alopecia. We're only going to inject the mesotherapy cocktail where we've got a sign of baldness, okay? And it's very important because do you remember the anagen phase requires the growth factors, and the mesotherapy, we're going to provide those nutrients necessary for the anagen phase. So definitely injecting the mesotherapy cocktail only where we have the sign of alopecia. So the following results were observed about, among the 20 patients, which the study was done 5 years ago now, okay, treated after one session with the combined, what we call one session is the protocol, treatment using Mesogun to inject on the scalp. So we use the Mesogun, but I prefer now to use the needle, okay, and follow week 1, week 2, week 3, and week 4. We follow each of our patient. 5 criteria were assessed by the patient with a scale to 0 to 10, 0, no improvement, 10 improvement above the patient expectation. So hydration, obviously, the glands, straightness, thickness, and firmness of the hair. So week 1, as you can see, we already noticed score 6 for the hydration and the glands. Week 2, we score 8 for the hydration and glands, 3 for the firmness. Week 3, score 10 for the hydration glands, 7 for the firmness, and 3 for the thickness. Noticed by not only the patient, by the patient and the hairdresser. And week 4, score 5 for the thickness and 8 for the firmness. And even one patient with allergy type 2 following dyeing agent had no reaction after dyeing her hair. The hairline mark disappeared, including the itchiness. So very good outcome noticed by the patient. So global patient satisfaction 100% and practitioner satisfaction 100% because it was over our expectation. So you can see just after 3 weeks on these male patients, we can see that, you know, the hair become thicker. You can see after 6 weeks on this patient, as you can see here, and here it's fuller. We can see as well the hair, they look more silky, so more soft when you touch your hair. So this patient recommended, you know, I recommended her not to dye her hair anymore. So she decided not to dye and to leave her hair naturally. We can see here, but okay, I know that I'm not a photographer. The quality of the picture is not great, but the most important is what we notice. We notice that on the top picture, it was before, we can see, you know, the hair are very dry. As you can see here, you know, they can break easily, so ready to dye, okay, ready to fall. And on this picture, as you can see, they're already fuller, they look more silky, and they are silky, they are more soft touch, thicker. There is another picture, different angle. As you can see, it's fuller, and definitely the quality of the hair is much better. So to conclude, the injection of CE mark cocktail, and it's very important that as Society of Mesotherapy, we promote CE marked for injection and not other cocktail, okay? Classic mesotherapy technique, classic compared to with a Mesogun, okay? Combined with botulinum toxin, helps to act on all the parameters of aging, oxidative stress, nutritional deficiency, cellular metabolism, angiogenesis, seborrhea, quality of the hair, and hair straightening. So those two techniques together, okay, and the protocol show very encouraging results in preventing the hair loss, in improving the quality of the hair, in increasing the success of hair graft and by promoting the regrowth. So it means that you can offer this treatment to your patient who had hair transplant. And obviously as well, which is very interesting, in reducing the blow dry the hair, which is damaging. In fact, what patients notice as well is the hair, after a shower, they dry quicker. Drying quicker, so they blow dry less longer, and we know blow drying your hair damage the hair and the keratin. So we've got a double, you know, effect. So polyrevitalization solution act against all effect of aging. Terima kasih. Merci.
Terima kasih. Thank you, Dr. Philip. Yes, now it's time to question and answer. Dr. Philip, about the toxin that you use, it diluted by a standard protocol into 0.5 cc saline for 100 units.
Correct.
Yes.
Yes, yes. It's a standard protocol regarding, you know, is exactly the same that like a hyperhidrosis is exactly the same than, you know, when you do for the face. There is no specific dilution, obviously.
Okay. And what's your recommendation for the mesotherapy ingredient, active ingredient to use polycomponent for?
So as a Society of Mesotherapy of UK, we're not here to promote one brand over another brand, okay? This is very important. We have to choose, you know, a cocktail which is CE marked. In my practice, I use NCTF 135HA, but you have to choose a cocktail which is safe, who's got, you know, a lot of background, say patient safety and practitioner safety as well. So in my practice, I use the NCTF 135HA from Filmed ex Filorga.
Okay. In the scalp region is quite pain if we inject to the scalp. You do the nerve block before you inject?
No, okay, no, definitely I don't use any numbing cream, anything. It's not very painful. It's less painful for women than men, actually. Women can stand the pain better than men. And we all know that.
Yes, agreed. Now we'll check the box art. From Dr. Novi, how many times does it need for mesotherapy Botox needed to see the result?
Okay, for the patient can see the results, after the second session of the second session. So the first session is mesotherapy with the Podium toxin. Second session is 2 weeks after already, the mesotherapy by itself. So 2 weeks to 3 weeks. And the third one is already, mesotherapy as well by itself. As you saw on the previous patients. So this patient here, when he came to me and for the second session, just after 3 weeks, he said to me, "Oh, I can't see any result, anything." So it's very important to take a picture. We always take a picture before and we take a picture after. And this is very interesting because the patient, they don't see a result straight away. Because we used to see our face every day. And when I show him the picture before and after just 3 weeks, so the first, just a lot of injection coming for the second type of injection, he could notice an improvement. So to come back to equations, it depends the patient, obviously it depends the age. Younger the patient is, better the result will be, and quicker. But after the second session of the mesotherapy, when they come for the third session, they can see already a result because you remember, so the hair follicle grows between 1 to 1.5 centimeters. So we're already in 4 weeks, 5 weeks. So there is a growth of 1 centimeter already, and they can see some baby hair growing. Bear in mind, okay, you can have a fall before, following the first treatment, which is normal, because the new hair follicle growing are pushing the dead follicle. So very important to mention to your patient, they might find a bit more, dead follicle, but there is no concern because the dead follicle are pushing by the new one growing.
Okay. Dr. Julia asked, if we are using Mesogun, what depth do we use? And for Botox, we need 50 units for each area or totally?
So I would not use the Mesogun for the toxin because we have to be very, it's very sensitive to the pressure. So we need to use the needle, okay? So we go to 2 millimeter depth, okay? And no more, obviously. We need to target the muscles. So this is very important, okay, to be in that depth, okay? No more than 3, definitely. And it has applied the same for the mesotherapy. Mesotherapy I do with the needle now. So I use 30 gauge, 13 millimeter, and angle of 30 degrees. I just, I'll go to 2 millimeter.
In total, 50 units for scalp or per area?
Yes, no, 50 units for the whole scalp. Okay. 50 units for the whole scalp, definitely.
If we face the small alopecia areata, we need just a little.
So if it's alopecia areata is a different treatment. Mm-hmm. So we're going to talk about steroid, cortisone, okay, topical or injectable. But the mesotherapy is not the main concern. Is the main treatment. We're going to use more steroid, which is the first treatment choice. Okay. So this is very important. But you, for alopecia areata, yes, you still can use, the mesotherapy, but it's not the main indication. The main indication for mesotherapy, it's, for androgenic alopecia.
And the other question about the toxin, how many units per site for toxin, it's already answered in total area. And Dr. Maria Angelina asked, Dr. Philip, do we need to repeat toxin every 6-month interval?
Yes. So the treatment, the protocol is 3 sessions, 2 weeks to 3 weeks maximum apart. The first session, I repeat, is combined botulinum toxin and mesotherapy, then 2 weeks to 3 weeks after mesotherapy by itself, and 2 to 3 weeks after, again, mesotherapy by itself. Then we repeat the protocol, 6 months after the first session of the mesotherapy. So the treatment is twice a year. Remember, when we used to do mesotherapy for alopecia, it was 10 to 12 sessions. Today, we're talking about only 3 sessions.
When the result doesn't come as expected, do we have to stop, and when we decide to stop the treatment?
So if it's always good, for the moment, I had a very good result. It's very important. So if we have no result, so we are not dealing with androgenic alopecia, we're dealing with something else. So it would be good to have to offer to your patient to do a full blood test to see if there is no, iron deficiency, if it's not thyroid issue. So I think really definitely, concerning find out why the treatment is not working, because the treatment should work. It's effective for androgenic alopecia because we saw, by science, then it does work. If it does not work, we are not dealing with androgenic alopecia, we're dealing with a different alopecia, which might be, areata, so stress related, so offer a blood test to find out what is the serious, what is the reason why. But a lot of time, thyroid can be the issue, iron level as well. So it's why this blood test can be very helpful to find out a bit, investigate a bit further.
Yes, thank you. If the patient had toxin injection on musculus frontalis before wrinkle pupus, before the treatment, does he or she need it?
Yes, because we're targeting, just at the hairline. This is really the hairline. So if you do classical toxin for the wrinkles, for example, we're targeting a different frontalis, because we know the frontalis muscles are, there is different type of frontalis, So we're targeting the frontalis, which is really the hairline. And when we do the face, we go lower. So definitely we have to do the frontalis hairlines.
Yes. Dr. Philip, I'm curious if we do the toxin only, not including the mesotherapy, are the scalp will be dry?
No.
Because the sebaceous
No, because the scalp is not going to be dry. We have an improvement. Actually, we have an improvement of the quality of the skin because and we see it. So on a patient with a lot of sebaceous gland, which is going to be reduced, but there is no impact on the dryness of the skin. Definitely not. Definitely not.
Yes. Okay, I think it's no more question from the chat, live chat box. Maybe you can make a conclusion or take home message for participant.
Yes, so this Congress is amazing. The topic are very, very great. My colleague just before, Dr. Andrew, has done an amazing presentation about, acne. And we know that it's very interesting that, acne scars, when someone come to you, the skin quality is paramount. So no point to do any other treatment if you don't treat the skin first. It's why your Congress, eye Congress, is amazing because, you're focalizing not only, you know, on injectable, but on the skin quality. And I think you understood, the Congress understood the importance of making the importance of treating all aspects of aesthetic, but dermatology as well. So I would like to say thank you very much for inviting me and inviting us to talk about, you know, all those different topics.
Thank you very much. Thank you for a good presentation. I believe this session will be bring us more new update and benefit to all participants to better practitioner in daily practice. Great pleasure to share this session today, sir. Thank you.
Terima kasih.
Terima kasih.
Bye-bye.
Bye-bye. And for all participants, don't forget to join our next session in Iswam Virtual. Have a great afternoon. Wassalamualaikum warahmatullahi wabarakatuh.